All right, guys, welcome back to another amazing episode for the Sleepwell Journey. I am so excited about this guest. We have such a treat for you today. I have my personal hygienist and myfunctional therapist, Tara Arnaud, in the hot seat. We are so excited. I'm Dr. Callie Hale.
And I'm Dr. Kyle Hale.
And we are ready to discuss all things myofunctional therapy. So thank you so much for coming, Tara.
Thank you.
Yeah.
I appreciate it. I appreciate you giving me the opportunity to speak.
Oh, well, we're so happy to have you. We have a million questions our viewers are constantly asking about myo and kind of our secret sauce of how we did that here. So we're excited to chat about it.
Yeah, totally. I do want to, before we get started, because we just came off of a weekend at the Dental Success Summit in San Antonio.
Incredible weekend. One
of my longtime mentors, Mark Costas, he puts on that event. And Mark Costas has a very famous dental podcast called the Dentalpreneur Podcast. And when we get asked these questions about our podcast, usually I learn from these questions because they're really helpful and insightful. And I got asked a handful of times by several people because it's a community that's very encouraging of what we're doing, because the podcast is not a typical thing. And then sticking with the podcast, I think, takes work, and especially on Lee's part. And so one of the questions I got asked is, how did we pick the name? And so before we jumped into it, I wanted to share how we named it. And we were getting a lot of input from our friends and from colleagues, people who, some people that we knew, kind of in the second degree, who were in media, who are in radio, and they gave us recommendations. And I felt like if this is something that we wanted to keep doing and stick with, it had to be something that we were excited about. And I think the name is also something that you're excited about. And so we called it the Sleepwell Journey because I wanted to make sure that we use this time, and for anyone that listened, to talk about our personal experience, me more on the admin side and you on the clinical side, going from a general dental practice that was doing well to a general dental practice with a humongous ortho and sleep component that's, firing on all 15 cylinders. I mean, it's a really strong practice. It's a really fun place to be, I feel like. And so all the hurdles that you had to overcome, all the hurdles that the business had to overcome, how we did that. And so that's why we started this. But what I also realized is that we're still on that journey, and having all these different guests on have been really helpful in sharing what those next steps of the journey are like. And so, we've talked to people who are in speed and agility coaching, people who are today myofunctional therapy, and from all the way back to audiology and nutritional counseling. And so there's a big circle here around wellness, and our goal is to talk about wellness and the implementation from a doctor side, from a community side. And so
and it is a journey. It's been an incredibly rewarding, very difficult at times, but journey.
That's what a journey is supposed to be. It's not supposed to be easy. If it's easy, then the treadmill's set too low. Right. So
definitely.
But let's get into it, because I got a bunch of questions for Tara. I've only known her for, let's see, when I met you, I was in high school.
No. You're terrible.
No. But you have been not just, to me, you are an advocate for the business that I own, and you don't own any of it. And that has always held a really special place in my heart. And I know in Jay's heart and Callie's heart. And just like you guys as a duo make us, y'all are foundational in this practice. You're not just you're not just team members or employees, but I mean, you're foundational. And, it would, every dentist would thrive. Every owner would thrive to have even just one person like you on their team. And so what I hope people get across from this episode is they can see a little bit of your magic, and and then maybe set the expectation a little higher for their own hygienist, or even just non-professionals on their team, because you have not only been, you're just smiling all the time. Your patients love you almost every time.
And my biggest cheerleader ever.
I believe that, we see success in the chair. So when we see that, it inspires us to keep going. And like I told people, that I can't look at them in the eyes and say for them to go on this journey with us if I truly didn't believe it.
Absolutely.
Mm-hmm. And I've seen your cases and the results, and they're beautiful. And I wish I had this for my kids when they were younger. So
awesome. Because you do go to other offices, and you do go to other CEs and outside of the office, and you come back and you tell us how you had to, get in this person's face about
or just defend your
IPR
right.
or sealants or whatever it is. And we have an alternative practice. You're here every day.
Right.
And so what has that been like going to CE and other offices when you're doing some kind of like temporary work or covering for other hygienists? What is it like?
I think it's very frustrating to not know, for them not to know what we know.
Right.
So once we know it, we can't unlearn it. We can't not see it. And so when we see these dysfunctions and these different patterns and they're narrow and they have tongue ties, it's hard not to address. And I believe that, education's changing, research is changing from a couple of years ago, and we're going to start seeing it more. And hopefully it opens the communication between other dentists so they can start being accessing this.
So when we bought this League City practice, which is almost 10 years ago, you were here before we owned it. And I would love for the listeners to kind of get a taste of what that journey has been like, because I definitely came in with, I didn't know what this place was going to be like, but changing from your traditional bread and butter dentistry practice to a more holistic practice, and then you deciding to go get trained in myo. Tell them your story.
Well, I worked for 20 years for a previous dentist. You came in and you had a more holistic approach, which I embraced, and I did my research on it. And I started to understand it. Mm-hmm. And it changed the way I spoke to patients. It changed the way I live. And I see just the benefits of our functional airway journey that we've been through. And then in 2019, we went to Colorado.
Yeah.
And they started speaking about myofunctional therapy. Yeah. I was in speech therapy for 2 years. And
I don't think I knew that.
Yeah, and I sucked my thumb till I think I was 10 years old.
Yeah.
So I had all these dysfunctional habits and problems when I was younger. And it really just hit home when I started hearing about myofunctional
had
therapy.
You had that
right
then.
Right.
Amazing.
Yes. So.
Yeah. So there had to have been, maybe not, but some time where I was having a different opinion on fluoride and amalgam. Can't have been that easy. I mean, I'm sure there could have been times where you were like, what is she talking about?
But I would research it and research it and research it. And from when you started owning the practice till now, the education and the research has it's changed so much. But yes, I did have a different stance on it.
Sure.
But once I started doing my research and started understanding it,
made it a little bit easier.
It made it so much easier. And I would be texting you at night, sending you research, sending you articles, and I would question you.
Of course.
Because I had to question you to understand it.
Right, for sure.
And you would help explain it. And then once I started getting that, seeing what my patients know and getting the way you were thinking and how you held the standards, I could implement it.
Awesome. So. And that's just a testament to you having an open mind too, which I think is really, I had my own moments in our journey getting out of dental school. Kyle and I both having conversations of like, wait, is this real? Like what I'm learning now that we didn't get when we were in dental school. And I just want the best for my patients. So if there's anything toxic in our materials or anything else, like, gosh, like I need to know about that because I'm the one that I look back
at products that other offices have used in the past or that still use, and I am floored by some of the things that are in these products.
So when we first decided that myofunctional therapy, which was not initially implemented in the airway stuff, I mean, it had to have been like a year, I think, before you and I started talking about you going and getting certified, because even then it wasn't as well understood.
Right.
As to like how much that was going to benefit my patients that are in oral appliance therapy, regardless if they were going to have a frenectomy or not. But that we realized like how badly we needed to have that in-house. And I remember when I was like so excited that you were going and getting trained, but that had to have been like the most stressful weekend and like drinking from a fire hose. What was that like?
It was overwhelming because I had to understand it too. I had to see the cases. I wanted to believe it, but
Right.
I had a lot of questions.
Sure.
And I believe, so when I took the course, I just kept going on the way home, like questioning everything. Like, is this correct?
Right.
Like, could everything that they've given me today, is this going to be beneficial?
Right. Or possible. Like
how
what
is it
they're
gonna,
claiming.
Yes. And now with my patients that I see and the cases that I see, I know we're doing what's right. I know that there's an impact. And Dr. Zaghi has said from 2019 to 2024, the research is there. It wasn't there 2 and 3 years ago. Right. It's there now.
Right.
So we have to look at, have to look at the tongue and how it affects the posture and the facial development and our speech. And there's so much to it. It's a huge, it's a big muscle. It's comprised of 8 different muscles, but it definitely plays a role in dentistry.
Definitely. Yeah. Wow. It's so crazy to me to think, because I remember I was so ready to have all of these options for our patients doing all this stuff without having a ton of literature to back it up back then, right? It was just, hey, this has been around for a long time, but you wouldn't have found like white papers 75 years ago on it. Even though myofunctional therapy is not a new practice, it's just not common like right now.
It's almost 100-year-old practice.
Yeah.
And orthodontists started doing it in the early 1900s, and then they
like invented it.
They
and
invented I don't know if the techniques are similar and how much it shares, but the concept of using your oral facial muscles to make changes to the oral facial hard tissues it's 10 decades old, if not more.
Absolutely. And I just remember thinking, like, whenever the rest of the world catches up to this, I want to have been a decade ahead of them. Like, I'm not one that's like, well, we're just going to wait until the right paper comes out or no, there's no way you're going to do any harm by this.
That's right.
And I think that there's a lot of questions and a lot of pushback, but that's the great thing about it is that we've had the pushback so we can learn and we can utilize our cases and show them that this works.
Absolutely.
Because I believe that the tongue is the expander and the lips are the braces.
Absolutely.
And
I love that. Gives me chills.
If we understand that, I think that we could correct a lot of the relapse that we have with certain cases.
Absolutely.
Okay, so I want to talk about the difference between. I get this question asked a ton. All right, and so on the ortho side, especially, they're asking me as a dentist. They're a dentist owner. I'm a dentist owner. How are you implementing these systems? So just on like the business side, the admin side, how are you implementing these systems? And they're asking, should I go to my associate docs and train them first? Should I do this first? And I'm a huge advocate for dentists are reactionary kind of trained. They're reactive. That's how they see a cavity and they fix it. Whereas hygiene was trained on prevention and preventative things, so they're proactive professionals. And so I'm a huge advocate when I talk to docs, train your hygienist. Let's talk to the hygienist first, give them the understanding, give them the tools, give them the time. And I know we made a lot of mistakes and continue to make a handful of mistakes, but I know we made a lot of mistakes when we started doing this with not enough iteros or not enough time for new patients or not enough clarity on what we expected from each patient. And especially with like the newer hygienists coming in here, might not be new to hygiene, but they're new to us. And so they're not drinking from a fire hose, but they're like, well, I got to change the way that I think. Right. So when you're talking to, maybe you could go back to when we made this change, I feel like with airway and with ortho, especially with airway, there's a huge opportunity to get more fulfilled at work because you're talking to your patient about something that isn't just bacteria on your teeth.
Correct.
We still have to have those conversations. Dentists still have to be dentists. Right. Hygienists still have to be hygienists. But it's an opportunity to expand the scope of what we do in the conversations and the level of professionalism we can have in the chair. So what are some of those hurdles for you, not like the learning hurdles, but the conversational hurdles that you have with new patients that come in? They're not here for airway. They're here because we're a dentist's office.
Correct. And so they're still our patients, and our job is to educate them.
Mm-hmm.
So we still do, the x-rays and the cleaning, and we discuss the bacterial level, but there's a component to that. And we have to educate them and give them our understanding and our view, even if they don't want to hear it.
Sure.
We still have to give them that knowledge. So I believe that taking that 5 minutes maybe away from the exam to just look at and access their tongue and look at the position of it and look at the asymmetries and look to see if they're nasal breathing or mouth breathing, and just start writing this down so when the doctor comes in, they can look at this. But we have to be the eyes to help y'all address it.
Right.
So I think that just getting that extra 5 minutes to put into the exam to do the assessment on these patients is really a huge deal with the therapy that they would, in the route that they would go. And I think that, just starting to plant that seed so they can understand it and do their own research.
And so other dentists would tell me, I tell them that same thing. I tell them, don't implement this thing and add just a handful of time. But we got to train, like, especially when you're hygiene that are new to scanning.
Right.
Like, you got to give them time to learn to scan.
Right.
You can't ask them to do 4-minute scans when they've never touched one. So, but the first thing they'll say to me is, after we get over the time thing and the training thing, is, well, my patients aren't used to this. And my patients will push back. And part of me is like, so?
Mm-hmm.
But because the truth is, I don't think there's that much pushback. I'd say I think I've done 10 hygiene exams in the last 6 months. That's a lot. But you're in the chair, you're having these initial conversations. And I do understand a lot of time co-diagnosing is such a strong tool for our young dentists to have experienced hygienists co-diagnose and edify the new dentist. So, I mean, are you getting a lot of pushback from patients? Are they telling you that you're a quack and that this isn't real and they don't want to know anything about it?
No, because we give them the education and we speak to them and give them the verbiage and show them cases. And so I don't get the pushback. Right. Even from our existing patients that
that never heard it before.
That never heard of it before.
Right.
They walk into this office and there's plenty of new patients that they didn't come to us because of airway.
Right.
But I always say that people get used to living in their dysfunction.
Yeah,
so people get used to not sleeping. They think that it's just because we're aging and that's what we're supposed to do, not sleep. People get used to their dysfunctions of, oh, well, I only have to sleep 5 hours. That's not right. Or I'm oversleeping. Like,
that's why I'm tired. Yeah. I'm oversleeping.
Yes, I slept 10 hours. So we get used to our dysfunctions. Right. So it's our job to help educate them about how important airway is. Mm-hmm. And I believe that airway is a huge component to functional health.
Absolutely.
Yeah.
And that is why Eastern medicine, and it goes back centuries. Hundreds of thousands. Yes. That's what the focus on. And I feel like our society gets really focused on these other elements of function, right, when we need to go back to the basics, and that's airway.
Absolutely.
Because that is, I believe, the most important thing.
That's so interesting that they've told you what they told you, that they're getting pushback.
Their patients won't tolerate it.
In my experience, having the mentorship program and really pushing these doctors hard, like, we have hard conversations. I tell them, if the patient's not accepting treatment, you failed. Like, we need to look at what you're saying. This has nothing to do with the appliance. This has nothing to do with anything besides
treatment coordinator.
Right. And blame it on whoever else they want to blame it on. Because that is absolutely an excuse. And one of the doctors that I mentor, I was chatting with last week, and I said, listen, like, you deciding, and I used one of your favorite phrases, which is the most recent painful memory. Okay. You've said that to me enough now that it's in my mind, that we are always going to remember the most recent painful memory. And I'm like, maybe if one patient challenged you, and maybe not even rudely, that they're going to use that as, oh, the patients are giving me pushback. Probably what happened is the patient asked you a legitimate question that you were unable to answer. And you took that as a defense of, oh, they don't even want this. And I didn't really know how to say it. So this is just too much for me. And instead, push yourself to go get educated in it and find those answers. And that was me for years. I would literally be in these holistic Facebook groups, these neighborhood Facebook pages, listening to these parents talk about this supplement that they tried or that. And I got so much of I need to look that up. I need to research that, literally from these very educated moms. And so anyways, yeah, I
think
find that really
we're constantly learning.
We are.
And, just like serapeptase and Kinlog, everything's changing with like the
Frenectomy
protocol. And so I believe that, you have to constantly be educating yourself and educating yourself, not just with the professional side, but the community side.
Right.
Because our moms are just as smart. Our moms understand. They're
100%.
looking for other options. And so when you look and listen to what other moms are saying and dads, and also getting your getting your education from the professionals, I think that'll come together. But if you don't embrace both sides, then I think you're not going to completely understand, because you have to understand to be relatable to your patient in the 100%. Chair. So you're going to be able to speak to the mom and say, yes, I know about that supplement.
Right.
Yes, I know about this. I know about that.
And I recommend that. Or yes, I recommend that one.
Right.
Whatever.
And
I got to say amen to that, because your mindset as a professional that the moms are smart is totally not what your traditional orthodontist, your traditional oral surgeon, your traditional specialist, and most dentists, they would not agree with that. And they'll come out guns blazing. And like, this is old news for us, but I'll repeat it here, that there are many gray-haired bald dentists that will die on the hill of fluoride. And if you don't want fluoride, I'm going to kick you out of my practice.
Right.
Still happens every day.
And that still happens because they're crazy. They would rather die on a hill that doesn't have concrete science, that is okay. It works really well in a laboratory, but maybe we can't prove it works in the mouth that well. But you're going to die on that hill. You're going to lose that relationship with that patient when you could be one of the best providers in the county or in the state or whatever.
And they ignore the fact that we do know that there is evidence against the neurological impact of it.
Oh yeah, well, it's cancer causing, but not my patients. Well, those guys, their patients don't stay there long enough to get cancer because they go to another place because you're a jerk. But anyways, I think your mindset of they're smart too is, this is new.
That's why we're successful.
Airway is new.
Right. And
we look at the early, I do this on the podcast a ton, Tara, where I think Airway is 30 years behind implants, because dental implants 30 years ago, from the stories the old timers tell me, is that you were a charlatan in a dental school if you were placing implants, and you were not going to get support from your dental school. You were not going to get support from your oral surgeon if you screwed up an implant.
Your insurance or anything. Yeah.
And we're there right now. Right. And I think, we've just broken through what would be like the bleeding edge into that cutting edge of airway science and airway dentistry and airway medicine as a team approach, not just a solo provider approach. And as it changes, the people that matter are the patients. And if we're not listening to what our patients are saying because we assume they're stupid, then we're not going to grow as a profession. Early on, an implant was always a success the day you put it in. But you know what? Patients didn't pay and go through the procedure to have it work the day you put it in. They paid and went through that so that it worked in 10 years, in 15 years, and in 30 years. And what we found out with the old materials is, they didn't actually integrate. And we had to get around that. And then what we found is, we found a material that integrates, but now we can't find a prosthetic connection that will actually last. Then you go from external connection to internal connection. What's the best internal connection? And we really just made it through 30 years of trial and error.
And that's what's happening now.
Because we had to see the outcome of the patient. But we're talking about single tooth or multiple teeth replacement. What we're talking about here is someone sleeping better at night so they wake up with a lower risk of heart attack, that a child can develop with full arches without snoring, without OSA, without those complications.
And who puts the kids to bed if we're talking about kids?
Nailed it.
Not the doctor.
Exactly.
Not the dentist. Yeah. Not the hygienist.
Not a pro.
So we're putting them to bed. Mm-hmm. We're checking on them. Mm-hmm. We're seeing that their mouth is open.
And
we're seeing that they're snoring. We're seeing that they have night terrors. Mm-hmm. We're dealing with this.
Bad dreams and
we
sweating.
have to be, the moms and dads are the advocates for the kids.
Right.
So the doctor has a limited time to spend with the patient. So the mom has to come in and understanding, and then we're going to give her, our education so that we can correct this.
Yeah.
We can make things better for these kids, because we've seen what a huge impact that our treatment plan has provided to our patients. We've seen behavioral changes. We've seen blood pressure changes.
Oh my gosh.
We've seen different, the way they speak, how they breathe. This is huge.
How their gums look even, and how they're aging.
Right.
Yeah.
Well, I used to think when I was a hygienist that people just didn't brush their back teeth. I thought they didn't get back there.
Yeah.
I didn't realize that people couldn't put their tongue to the second molar.
Mm-hmm. I mean, I couldn't until my
after I
frenectomy.
brushed my teeth, I just always have felt around to see where that plaque's at. But then I realized that people that are so tongue-tied, they can't do that.
I couldn't.
So then I'm over here not almost judging a patient because I didn't understand it.
Yeah, you were missing what was right there, and we didn't even know. Or I was
missing that patients were mouth breathing, their gums were red, they were inflamed. I didn't understand.
Yeah.
Now I understand, and I feel guilty, actually.
Yeah.
Because we put OH poor. That's it.
Yeah.
Learn how to brush
Calc
better.
plus plus.
Yeah. Learn how to brush better. Floss. That's it. Okay, goodbye.
Oh my God.
And so now we're learning, this is a reason that you weren't able to get back there. You didn't feel that you didn't get that plaque with the toothbrush. You're not nasal breathing.
Right.
You're breathing through your mouth. Those crowns, we thought, the crowns don't really, but it's the margins. The margins don't look good on those number 8 and 9. But really, it was so much of that mouth breathing, too, that was causing that inflammation. So I think I do feel guilty because I didn't know.
Same. I mean, I say all the time, my biggest regret is telling a parent that their child snoring was normal and they'd grow out of it.
I don't know how you two can live with yourself by not knowing something you didn't know.
But I mean, that's why our patients love us, okay? Because we truly I feel like you and I both take it home with us, which we shouldn't, but they're especially early on with these cases of oh my gosh, this just we have to help the child. We have to. And then once it became you were just helping all of them and it was just a very predictable outcome, it's really rewarding. But yeah, I was taught wrong, so therefore regurgitated it wrong.
Yeah.
Well, you brought up kind of like a perio thing in your little last rant, so I want to pick on that a little bit. You talked about seeing inflammation and plaque on teeth that you couldn't touch with your tongue. And I remember, well, actually, side note, the first time Callie asked me that, I don't know if it was you had just come back from your training, but she's like, "Can you lick your second molar?" And I was like, "Yeah." And she's like, "How far back?" And I was like, "I can lick my hamulus." Okay.
He's not tongue-tied.
Yeah.
Okay.
I can. Yeah. And so if I could get to my pituitary, I could probably get it, but I got a big tongue.
Some skull in the way there.
But it never crossed my mind that was a thing either. And even though we see it, and then in kids, we do grade it. And so on the perio side, and maybe we're talking more about adults. On the perio side, what are the benefits? So if someone comes in and they don't want to do ortho, but we talked them into the myo, which is, another form of orthodontics. What are some changes you've seen in perio patients? Like not our non-perio, like specifically to our perio patients, like, do they benefit from this on the perio side and the hygiene side? It sounds like you're trying to say that they are, but what's your experience?
I believe that they are, because we're getting that inflammation down. We're trying to establish that nasal breathing and the lips closed. So I believe that has a big impact on the gingiva and the inflammatory response. So I do believe that there are changes, and we will probably continue to start seeing more research on that.
For sure.
But right now it's just limited.
Okay.
I think what's been really cool for Tara and I with these thousands of kids over the last years that we've treated is the amount of, in kids specifically, mouth breathing and plaque and gum irritation, especially on those front 6 teeth. I can just walk in now and do a consult and see it all on there. And I know it's not the parent, like not brushing
Right.
their teeth. Like
Right.
they are, and then they wake up the next day and all that stuff's there again, you know? So I think that's a real important thing with the ADA calling us to screen. You know, we have that paper in the front of our office. When you come in, like you see it's all framed that like we are supposed to screen for sleep disorder breathing.
Right.
It's got to be fairly obvious as a hygienist. One maybe tip, if you agree, is that when you're cleaning their teeth, if they're not a nasal breather, you're going to know, right? Aren't they like
But we didn't know
holding their
that.
breath?
But
Sure.
still, we
Right.
didn't know that. We thought they were problem patients.
oh my goodness.
We thought
oh
that
my goodness. Yeah.
Are the gaggers? We didn't understand that they might be tongue tied. We
Right.
didn't understand that. We just thought they were difficult.
Right.
So if you're
And-
a gagger, you're tongue tied?
No, I mean, but there is a
Very high likely.
Yeah, there's a high. Yeah,
I didn't know that.
yeah, and then also, I mean, just the tongue positioning, right? If they have a low tongue posture, it's going to be hard
Oh yeah.
Yeah.
to clean the lingual areas of the mandibular mouth on the molars because they rest their tongue so low, or if they're tongue tied, their tongue stays low. So when they're going to brush, their tongue is sitting right there holding that plaque there. So they're not able to get in there and brush.
Wait, I have a serious question.
Okay.
Okay, because I did not know that, and now my wheels are spinning. We have a lot of edentulous patients. So I don't do exams, but I still pull teeth. I still do dentures. I still do implants. And we have a lot of patients that are edentulous or partially edentulous and are gaggers. Some of them severe. And if you know anything about a denture, you know that it is very uncomfortable if you're a gagger. And usually on those patients, we have to remove so much material off the back of the upper denture and the lower denture, so much so that we can't even make a good fit, even if they have great bony structures, to make a really strong fitting denture. But because they gag so much, so is my two questions. I got to write them down.
He's excited.
One
right
question: can you do myofunctional therapy on someone who's edentulous?
I have not
Okay.
done it, but I believe that it would be a great thing to do, because not only would we be helping get their tongue strength, because as we get older, we lose that strength, not only in the tongue, but in the soft palate. So our job is to tighten that and help tighten that and get everything nice and the tongue improved in their tone. And it will help that soft palate to help with different issues, because there's so many, especially
Sure.
aging
Yeah.
adults that start having swallowing issues, gagging issues, and they have aspiration, right?
Oh,
As they
for
get
sure.
older.
Yes.
That's a reason why a lot of older people pass away in the
Pneumonia,
hospital
yeah.
because of, the choking and aspirating. So I believe that it's only a benefit to help them,
Totally.
to help that community to engage in these muscles and get them tight, because we're working on everything else, but we're not working on what we use so much. And the
Right.
tongue is responsible for the eating and the swallowing and the breathing. There's so much to it.
Well, to
that goes
pretend
back-
like this doesn't affect that.
Right. So to go back to the functional aspect of the wellness that we're looking
Love
at,
it.
we have to look at the tongue. We have to look at the mouth, because we see what a vital role it plays.
So I think I'm gonna talk to I've got like 3 patients in mind. I'm going to send them to you
Yeah.
and see, and that'd be really cool. So part 2 of this will be us interviewing those patients in front of you and talking about but that's never even crossed my mind, not at once. Callie, you're really doing a terrible job at this.
Oh my gosh. Okay. Yeah.
I mean,
But I think it's
would,
just learning, right? We're just constantly
Yeah.
learning about what.
Why am I doing the terrible job?
What we've done right and what we've done wrong.
well,
And
yeah.
I think that we have to look at what takes us home, what makes us think about patients at night, are the patients that we don't see success.
Right. Of course.
So we question ourselves, and those are the ones that make us research more and speak. If I have questions, who do I come to? I come to you, because
Right.
I'm frustrated, because why isn't this going the way I thought it was going to go?
Right.
And so me reaching out to other professionals. So I think those cases that are harder and the ones that we didn't understand, or the treatment, we want explanation. And I think that's what that sets us aside from other
providers.
professions.
Absolutely.
okay, part 2. part 2 of my question.
I'm not done with your part 1.
We're done. Because I really
Okay,
gotta
do
get
part
to this.
2. Go, and then I'm gonna go back.
Because I feel like now I'm not understanding anything about myfunctional therapy.
Okay, go ahead.
We'll turn the cameras off. This is for college education,
it's
so you
not.
don't
No,
look like
it's
a
not.
moron on the podcast. But does myfunctional therapy only train the tongue, or are there other muscles of the face and the neck that it trains?
Yes, other muscles.
Does it do any
Because
of the?
we're looking at not just the tongue, we're looking at compensations of keeping the jaw stable.
Okay.
So we're able to swallow and speak and tone up the different muscles, because when we have a low resting tongue posture, we create different compensations. And so we have to identify that.
So she's training the lips and
Well, I'm thinking. I know we now require most, if not all. Maybe it is all. Maybe it's just most. But anyone that's going to get in our practice going to get a lip or tongue tie.
it's
done.
required. Almost
Okay, it
a
is
newborn
required.
baby, it's required.
Right. Okay. Oh, we got to get those numbers up on those newborn babies. Okay.
Okay.
No,
We require OT and Cairo for that.
I'm thinking
not
like if we have
specifically.
most of what I've done for the last 3 years has been surgery, and which the hardest part of the surgery that we do here is immediate dentures. So you're taking a bunch of teeth out on patients, you're throwing in these plastic Hot Wheels cars with white teeth buttoned up to them, and you're telling them good luck. And what we end up doing is for half the patients, we see them once a week for a few months, and the other half of the patients, we see them 6 months later, and they're just mad. Okay. And we do, I think, thanks to my father-in-law, Jay Elliott, we do a really good job setting them up for setting the expectation appropriately. We tell them things like it's a Hot Wheels car in your mouth, or, you're an amputee and no one will know because your teeth are straight, white, and pretty. It's every time you cough, laugh, or sneeze are going to come out, all those things. And I'm wondering, and what I've seen over my much shorter career than Jay's is there are patients who tolerate these dentures super well. There are patients who can bite into an apple with no implants. It's just their dentures. And I've always been taught, like especially in my prosthodontic training in dental school, is that these are muscles can keep them stable, can stabilize your dentures. And so my assumption has always been that if you just like any other muscle in the body, you can train it to do unique things. And if you're an amputee, I know the same thing is true. Now, I've never thought about, well, why don't we use this is crazy. I'm saying it out loud, but I've never thought about using myofunctional therapy, your treatment, to help with our denture patients to get through those learning curves.
I think it's brilliant.
Quicker.
I think it's brilliant.
I'm just thinking like, if you want an immediate denture here now, I'm thinking you got to go through, I don't know, 8 weeks or 14 weeks or something with Tara and help you shorten that learning curve. It's not going to eliminate it at all because it's still a traumatic thing to have happen to you, but it's something that's going to make them healthier overnight, which is my favorite part about doing immediate dentures. We're not taking out healthy teeth. We're taking out teeth that are like
infected and gross and right.
They are not great and are causing pain constantly and inflammation constantly. So, man, thank you. Podcast over.
Well, what I was going to add to when you asked on the first was,
okay,
why did these patients lose their teeth to begin with? Right. So aside from neglect, drug abuse, whatever.
I'm not making dentures for super white arches ever.
I know.
I've never made one like,
yes.
wow, look, it looks like a coffee plate.
All the teeth would have fit in this arch.
Yeah.
So this has been amazing because you're absolutely right. Like the pros side of things needs to have myofunctional therapy built into it, because if you have gotten to a point where you've lost your teeth, there was a reason for that. And the odds of that being an airway reason as your underlying root cause is very huge.
Right.
We're done. No, that was it. No, that was easy. No, we're done. You can't. I can't learn more today. I'm done.
I mean, that is the mic drop here because it's really important. So when I always think about too, like, okay, you get an implant, you keep breaking that screw off. You break the screw, you break the abutment. Yeah, like, well, yeah. If you can break your actual tooth that cost you to lose that in the first place because you had sleep apnea and nobody knew, you're probably also going to damage your implant, especially if it's the most terminal tooth with nothing behind it, and now all of your occlusal forces are on that implant.
That is why we try to identify early.
Yes.
So identifying early is going to help that patient not become his patient.
Exactly.
Yes.
Because I tell these parents all the time, your kids are still going to be smart. They're still beautiful.
Yes.
But we could help eliminate problems that you will see now and in the future if we don't fix them.
We're treating them at 6.
we're starting early. We're expanding them. We're getting that nasal breathing, that airway open, so they won't continue with this pattern, and hopefully not end up in his chair. Yeah. So I think we're doing what's right by educating them,
and that's
getting our
one
eyes on them,
yeah,
and finding out what we can do for them.
And that's one of the hardest things, I think, for the dentists, the hygienists, these dental providers, is to understand that what you and I are doing right now at 6 is changing how they are at age 40. So when we're talking to a parent that might be on the fence about doing any of this, it can be difficult if you haven't seen enough cases, if you haven't done enough cases, if you don't have a mentor in this area, to know that we are trying to make sure that your child actually ages well, and the consequences of which you would never have related to their orthodontic treatment, because now they're 45 years old.
Right.
And why would they have ever thought it had anything to do with their braces?
Mm-hmm. I'm seriously just sitting here.
Yeah, I believe that, because the expansion, them expanding,
changes the trajectory of their growth.
Exactly. And if they don't get that, if they're not in the cycles of sleep, and they're not going into REM and getting the growth factors,
right,
then we're going to see, you're going to see issues, and you might not see them now, because I do have to think this too, as much as parents are advocates, I do have to think about, I was talking to Wee about this. Most of our parents, most of the families, they're very, in this area, live in nice 2-story homes, maybe.
Right.
So they put their kid to sleep, and sometimes they don't get their eyes on them.
Absolutely. Mm-hmm.
So sometimes we are missing out. So we have to inform that parent when they're not aware.
Right.
Hey, can you go look at them? Because I believe that when we're supposed to look at them is an hour after we put them to bed.
Yes. Shortly after they've fallen asleep. Yeah.
So then we look at them to identify, and so they can we can help them if they're not aware, for them to go upstairs, which I know as moms, it's such a hard thing, because we're checking the homework, we're brushing their teeth, we're making sure they took a shower, we're making sure the lunches are going to be packed for tomorrow. Right. So it's another thing that they have to do. But I think if they're not aware, then we can make them aware of, hey, go look at your kid, make sure that this is not happening and this is not happening, because if it is, we can help improve that.
100%.
So something that kind of just hit me a little bit harder, not because, again, I'm still thinking about this denture thing in Myo, but something that just hit me a little bit harder is something that Matthew Walker said in the last time we saw him speak a couple of years ago. Mm-hmm. And he said something when we were doing it was really cool. We got to do kind of an open forum Q&A, and we're asking questions. And one of the folks there, one of the dentists there, talked about something. I can't remember what the question was, but Dr. Walker immediately responded with, "You have to remember that you never catch up on sleep. Yeah, the damage is done, and so the next time you go to bed, you are going to bed for the next day for that reparative moment, and so it's compounding when you think about it. When you sleep for 40 nights, and 39 of them you are traumatically sleeping, and maybe you get one good nights of rest. For adults, that can be for many reasons. For kids, that can be because allergies and nasal hygiene and underdeveloped arches, whatever it is. And that has to really, it would take a while for that to sink into a parent, because that would, in sports, we can always make these analogies of, if you're not practicing, someone else out there is, right? Someone out there is getting better. And while the kids who are born with the right phenotype and the right genetics and the right environment, or the ones who are in treatment, in my mind, are surpassing the kids who are not, the ones who are not breathing well at night, that are grinding their teeth, they are snoring.
They're tired.
They're tired.
They're tired in school.
And they don't catch up.
They're tired in sports. They're just tired. And I think we see that a lot.
All the time.
And we think that they're just being lazy. But they're really just tired. And I mean, I always even think about this when you see that kid at the grocery store throwing themselves on the ground.
I know.
Because they're probably just exhausted.
Yeah.
And as adults, we sort of cover that up.
Of course.
We don't throw ourselves on the ground, but there's so much rage and so much
Inflammation.
right, inflammation and high blood pressure. So this is very important if we're looking at the health of our patients. And I think number one, that's what our job is to look at the health of the patients and make sure that they're having a good night's rest and they're having nasal hygiene.
Yes.
And
Huge.
breathing through their nose and
Right.
getting that restful sleep because it makes a difference. And the studies have showed that there's chronic diseases if you don't.
Right. Absolutely.
So what, I want to switch gears a little bit unless you have something you want to get into. So I have a really good friend. His name's Aaron Nicholas, an awesome dentist in Maryland, and he runs this CE program called Monday Morning Dentistry. And if you're looking for a endodontic CE, I think he's got the best general dentist endo program on the planet. And it's where I went. And we're not huge advocates of endodontics here, but there are times and places that we do feel it's indicated. And he runs an awesome program, and he calls his program Monday Morning Dentistry. Okay. And because the sentiment behind taking CE is that, all CE, not just his, is that you're going to go learn something that you can apply Monday morning. Doc, you're here. You're going to take off work on Friday and spend your Saturday and Sunday here with us, and you're going to take home this, not just nuggets, but skills. And that's the big pitch, is that you come pay $2,000 to take our course, to pay $4,000 to take our course. You have something you can use. Well, I think that's true of Aaron's course in a huge way. It is hands-on. It is in your face over and over and over and over. You will leave with skills. I don't know that there is an airway treatment CE course that you can take in a weekend that is implementable on Monday. But what I do believe is that there is education in airway, in underdeveloped arches and orthodontics and malocclusion and the signs and symptoms. I do think there is something that you can learn in 2 or 3 days that helps you see your patients differently.
Absolutely.
And you can have different conversations. You're probably not qualified to be the treating provider
In that
Monday.
moment on Monday.
But what you still will do is you'll still be the person that helped that family, that person, that patient, that child, that adult, whoever, find a solution to maybe something they've been struggling with for a long time. So I'm saying all that to ask you a question. What is that one thing, or that 2 things, those 3 things? What is something that comes to the front of your mind when you're thinking, you're a hygienist of several years and you feel comfortable in your own skin, you feel comfortable with the flow of your practice, and you feel comfortable with your patients, and now you now learned something about airway. What is something that you think hygienists should be looking at first, or maybe seeking out on their own, so they can have these conversations, knowing that their doctor might not be totally behind it, or they might not care that they're having these conversations? What is there something that you can think of that's like, hey, if we have a new, like Dawn's new here, newer now. What would be your first piece of advice for Dawn? Like, hey, this is a lot. What's the first thing you tell a new hire here to help?
That's a good question.
To understand airway.
Maybe understand it, but how to, now I got to break your brain a little bit, because you're used to talking about teeth and perio and cavities. Now we're going to talk about tongue position and malocclusion and traumatic occlusion and clefting and
all the
spacing. And
So I believe that screening is the number one thing to do, because once you screen them and do maybe like Dr. Zoggy's FAIR test, the 10 elements that we look at,
Right.
then when you're going to start putting that piece of the puzzle together.
Yes.
So when you see it on paper and you're looking at these things and you're screening them, you're saying, oh,
You do have this. Oh, and
your
that's what
tongue,
you're thinking.
yes, your tongue is low.
Right.
You are mouth breathing. You do have a narrow palate, but you have to see it, so you have to screen it. So I believe that once you screen it, you see it and understand how we can change it.
Yeah. Oh, I
Makes
love
sense?
that.
Totally.
Oh my gosh,
Yeah.
that's great.
So I think that it's just about once we screen.
Get the screening.
Right.
And there
Because,
are really
yeah.
great specific myo tongue screening forms that
Right.
offices can implement.
Right.
that the hygienists can do and look at and have
Right.
that on
Totally.
record.
And again, like it just takes,
Yeah.
5 minutes for them to look at. So we could have another conversation if you don't want to have it in the chair.
Right.
So,
Well, I hate to wrap it up, but we are actually real life dentists and hygienists here. So,
Oh yeah, she probably is a patient.
yes,
Okay.
but I'm not going to let you go yet. So we're
Okay.
going to do this rapid fire. All right. We have a pass along question from the previous guest. Jackson Appel was our last guest, and we asked him his pass along question. Now I'm asking you the pass along question he gave to you. And that is, if you had 3 wishes, what would they be?
3 wishes.
About anything. Just 3 wishes.
3 wishes. Wow.
This is going to be a great way to open a podcast week.
3 wishes is probably to continue to stay healthy.
Yep.
Continue to have a close-knit family, and continue to educate myself so I can continue to thrive.
Awesome. That's
Okay.
really good answers.
I know.
I don't know how I could have done that. I
She's
probably would've said a
amazing, you
car.
guys. I'm so lucky.
All right. Now you have to make a pass along question for the
For
next
our
guest.
next guest.
Okay. What is the number one thing in your profession that you regret?
Ooh, that's really freaking good.
What is the number one thing in your profession that you regret?
Me?
Yeah.
For judging those patients.
Oh, I love it.
Yes.
This is awesome, Tara. I can't thank you enough. Seriously.
All right. Do you have any social media stuff that you want to plug?
We do, but
Okay.
we're still figuring that out. We'll get
She
it.
is going to have an amazing Mayo Instagram page that we will tag once this airs.
Yes.
Sweet.
All right.
All right. Thank you, Tara.
Thank you.
Bye, guys.
Bye, guys. See y'all.